Hello, I am Sonia SEGURA from Hospital del Mar in Barcelona. Pink lesions on the legs refer to a very common situation in clinical practice and correspond to a wide spectrum of conditions including skin cancer and inflammatory lesions. They are characterized by a paucity of diagnostic clues from both clinical and dermoscopic point of view. Here we have 4 clinical images and the corresponding dermoscopy of 4 different conditions affecting the legs. When we study hypomelanotic lesions, we have to take in consideration several structures that will help us in the correct diagnosis. Vessels, shiny white structures, the presence of focal pigment to exclude melanocytic lesions, the presence of erosions, ulcerations, or scales. This important article by Iris Talaudek, published 10 years ago, shows us all the different morphology of vessels in hypopigmented tumors. We have recently published a study about the accuracy of dermoscopy in the diagnosis of pink lesions on the legs in a series of 114 lesions. We found that linear irregular vessels were the most common structures in BCC, followed by arborizing vessels and short fine telangiectasia. Only these last structures was significant in multivariable analysis. In basal cell carcinoma, polymorphous vessels were frequent, that is, the presence of two or more vascular structures in the same lesions. Regarding Bowen disease, the most frequent structures were glomerular vessels and dotted vessels. Both structures were significant in multivariable analysis, although these vessels were also seen in inflammatory lesions. According to this study by Papageorgiou and co-workers, in the differentiation of superficial BCC and Bowen disease, vessels are useful in the sense that glomerular and dotted vessels, similarly to what we have found, are associated to Bowen disease, whereas fine linear vessels are more frequent in superficial basal cell carcinoma. However, they're only structures associated statistically to BCC or arborizing vessels. Let's see some of our cases. Here we have a case of Bowen disease. We can see glomerular vessels, more or less in a cluster distribution, and some dotted vessels more in the periphery. Another example with a detail of the cluster distribution of glomerular vessels in a Bowen disease. A case of basal cell carcinoma with polymorpho vessels. We can see glomerular vessels, hairpin vessels, and fine linear vessels. Another case of basal cell carcinoma with glomerular vessels and fine linear vessels. A basal cell carcinoma with arborizing vessels, characteristic of this tumor but less frequent in this clinical context, with fine linear vessels. A basal cell carcinoma with less frequent observed dot vessels in this case, and a Bowen disease with characteristic dotted and some glomerular vessels. Here you have an example of venous stasis dermatitis with a characteristic coppery background and many peripheral red globules with some glomerular vessels. Another case, this is the lichen aureus. We can see also in this case a coppery background and red globules. In a higher magnification, we can distinguish glomerular vessels. The presence of focal pigment may be a clue for diagnosis in the evaluation of pink plaques on the legs. We have to look for any criteria of melanocytic lesion to exclude a melanoma, pigment network, aggregates of globules, pigment streaks, negative pigment network, or even remnants of pigment. Also, we have to look for the classical criteria of pigmented basal cell carcinoma. And finally, it will be useful to look for some criteria described in pigmented Bowen disease. We have analyzed all these criteria in our study, and we found that classical criteria of pigmented basal cell carcinoma were rarely seen in our cases. By definition, they were non-pigmented. However, these criteria were never seen in non-BCC cases. The only criteria significant in multivariable analysis was the presence of pink-brown eccentric structureless areas in Bowen disease. Brown-gray dots ranging peripheral lines that are described in the Bowen disease were not frequent in our series. Let's see some examples of this focal pigment. This is two cases of basal cell carcinoma. We can see in focus blue-gray dots scattered all over the lesion. Some concentric structures here or spoke wheel areas, also maple leaf areas in the center of this basal cell carcinoma. Another example of basal cell carcinoma with focal pigment. Subtle maple leaf areas and also concentric structures with in focus blue-gray dots. Here you have a nice example of basal cell carcinoma with an ovoid nest, concentric structures, and maple leaf-like areas in the periphery. Here you have Bowen disease. We can see brownish eccentric structureless areas and also dotted and glomerular vessels. Another example, again, the peripheral brownish areas in this case with brown-gray dots ranging peripheral lines, quite subtle, and glomerular vessels in clusters. Another example here of Bowen disease. In this case, we can see more in detail these brown-gray dots arranging peripheral lines. And a very tricky lesions, a pinkish scaly lesion on the extremity with brownish eccentric structureless areas, brown-gray dots, dusty-like, not really in focus, polymorphic vessels, dotted and fine linear vessels. In this case, it was a melanotic melanoma. We have to pay attention to these remnants of pigment in lesions that have no clear-cut criteria for other tumors. We have analyzed the presence of shiny white structures in pink plaques on the legs, and we have seen that they are very frequent and in BCC, and this is statistically significant. These shiny white structures has been described in BCC in this interesting article. The authors classify these structures in blotches, strands. These two structures will be associated to BCC, but also they consider chrysalis and rosette as shiny white structures. But they see in the study that blotches and strands are associated to BCC, whereas other structures as chrysalis are more frequent in melanoma and not seen in BCC. Rosettes are seen in all types of tumors and not specific. Let's see a few examples. Here we have a basal cell carcinoma with very nice shiny white strands, some rosettes, and also hairpin vessels and fine linear vessels. Another BCC, again with shiny white structures distributed in blotches and strands with pink white areas and dotted vessels and fine linear vessels. Similar lesions, but in this case was a Bowen disease. Again, these pink white areas with shiny white structures and red globules. More in detail, we could observe also dot vessels. An example of lichen planus on the legs. We can see these shiny white structures, blotches and strands associated in this case to dotted vessels. Another example of lichen planus, in this case with the presence of multiple rosettes. A case of venous stasis dermatitis with characteristic red coppery background, red globules, glomerular vessels, and also shiny white blotches. We have also studied presence of erosions and ulceration as well as scales in our series. Erosions, ulcerations were significantly more frequent in basal cell carcinoma, whereas scales were present in all groups. Let's see some examples. Here you have a case of basal cell carcinoma with an eye central erosion and the presence of shiny white structures. Another case with erosion in the center and multiple shiny white strands. Also some focal pigment in the periphery with focus dots. A case of Bowen disease. Some of the cases were also ulcerated, although less frequently than in BCC. In this case, we see a large ulceration with glomerular vessels. Regarding the scaling, here you have typical case of Bowen disease with desquamation and peripheral gray-brown lines that we have already seen. A case of porokeratosis with characteristic desquamation with a peripheral lamella and fine lineal vessels. Finally, we have a venous stasis dermatitis with red coppery background, scales, red globules, and glomerular vessels. We finally calculated sensitivity and specificity of dermoscopy compared to clinical assessment, and we saw that dermoscopy improved diagnostic accuracy for skin cancer and exact diagnosis. However, specificity was low for dermoscopy in this clinical context. Confocal microscopy showed better results when used after clinical and dermoscopy assessment and permitted a high accuracy for skin cancer diagnosis and for an exact diagnosis. We proposed an algorithm that we will show you briefly. Here we have a case, a pig lesion on the anterior part of the leg. In the first step, we have to exclude if we have any criteria of melanocytic lesion from a confocal point of view. If not, we will look for the presence of basal cords or nodules in the apodermis that are hyporeflecting structures characteristic of basal cell carcinoma. If not, we will look for another criteria of basal cell carcinoma that are polarized honeycomb or streaming. In case of present, we will also have the diagnosis of BCC. In this other case, we don't have any of the previous criteria. Then we look for the presence of epidermal disarray. This was the case. We also had some targetoid cells. These two criteria are suggestive of Bowen disease. Finally, in this third case, we don't have any of the previous criteria, but we have dermal inflammation that we can see here with these bright particles in the apodermis. In the absence of other features, this is suggestive of stasis dermatitis. As conclusions, we can say that pink lesions on the lower extremities represent a clinical and a dermoscopic challenge. Glomerular vessels and dotted vessels are characteristic of Bowen disease, but may be seen in other lesions located on the legs, whereas fine linear vessels are more frequent in basal cell carcinoma. Focal pigment may help in the differential diagnosis between BCC and Bowen disease and to exclude a hypomelanotic melanoma. Shiny white structures are present in BCC but also in other tumors and inflammatory lesions, being blotches and strands more frequently associated to BCC. And finally, reflectance confocal microscopy may be useful in difficult cases to differentiate BCC from Bowen disease and inflammatory lesions.